it's Shirley Gutkowski again for the second time on a Facebook Live from our Primal Air Facebook page. Primal Air is in the business of helping you breathe smarter, not harder, and to keep families together and reduce family strife, I guess is probably the best word, and today we're going to be listening to Elizabeth Dooher Anthony, who is going to talk about the roots of dental trauma. And I think you may be surprised to learn where this kind of thing comes from and what we as dental hygienists can do about it in our first and even our, in our first exchange with a patient as a child on up to grown-ups. So Beth, take it away.
All right. Thank you, Shirley. Thank you so much for that kind introduction. I'm so happy to be here tonight and to share my experience and knowledge. And learning about oral myofunctional therapy was the absolute best thing I've ever done as a dental hygienist, because it's really helped me understand why patients act the way they do. So tonight I'm going to talk about the roots of dental trauma. Surdentity is a book I published in 2013. It's a webinar and a seminar that I've been working on for at least 20 years, trying to help dental professionals have more peaceful interactions with their patients. Every dental, pardon me, publication has articles about dealing with difficult patients, frustrating dental patients. I hate this patient. And there's entire Facebook groups devoted to trashing these kinds of patients. And my message to my fellow professionals is, yes, these people are annoying and frustrating, but many of these people have been traumatized, and they can be worked with. So here's my story. There I am in 1988, graduating from dental hygiene school. And that x-ray unit is literally what I was working with at my first office. And I had a barber chair, which was freaking great. And thank God it broke. But that's what we all looked like in the late 80s. In 1995, I was working at an office in Colorado Springs, and there was a woman there. And, in the meantime, I had noticed that, some patients were just really hard to work with. And this woman came into the office, and she had been the victim of a violent crime. She was very hypervigilant, very emotional, and she was in the operatory next to mine. And when the hygienist went to lean over her to start the work, the woman had an absolute panic attack and leapt out of the chair. And all of a sudden, the dots connected in my head, and I realized, oh my gosh, she's not reacting to the hygienist. She's reacting to the image of someone over her. She is not reacting. She's reacting to something that's not right there. And that's how I came to realize that, oh my gosh, patients are reacting not to me in the present as much as they are reacting to things that happened to them in the past. And that's how I began to learn about post-traumatic stress disorder. And a lot of my knowledge has also come from my own efforts at my own self-improvement, and learning things through reading, through counseling, and doing things to help myself be a better person. I've translated those into my profession. So in 2006 was the first time I put Surdentity together, and I presented it in Buffalo. It was great. And that's one of my main focuses, was that it's the patient's emotional experience that influences them more than anything else. I published Surdentity as a book. In 2018 was the very first time I was ever introduced to orofacial myofunctional therapy and started to understand about not just teeth. I took another course in myofunctional therapy, and that's where I learned about oral reflexes. And again, I started to connect the dots, and I realized that most oral movements are not purposeful. and patients are not trying to make my job harder. And that to me was such a relief. And what is my job? My job is to educate people and to advocate for them. So patient autonomy is the very first ethical principle behind my profession, which means that we have the duty to respect the patient's right to self-determination and confidentiality, and the duty to treat the patient according to the patient's desires, not mine. And that has been my motto, my professional motto for my entire career. And what happens is that patients come into a dental practice, and the dental professional puts themselves above the patient as a superior being, and comes up with a bunch of treatments for this patient that are supposedly best for the patient, but are they really? So the patient, and then the office has a policy of treatment, and if the patient refuses treatment, there's major panic. Nobody knows what to do. And there's article upon article in all sorts of dental practice management journals about how to get patients to do the treatment that you want them to do. And my question about that is always, okay, is this treatment the best for the patient, or is it more profitable for the office? A lot of office policies, especially in regards to refusing dental x-rays, are there to me more about fear. The standard of care is a phrase that we hear a lot about, because if a patient refuses treatment, then are we maintaining the standard of care? And after a lot of research, this is what the standard of care boils down to. The person has, the provider has to possess a reasonable degree of learning, reasonable care, latest advances, clinician's best judgment, exercise skill, approved methods in general use, and give proper instruction to the patient. This does not say anything in here about a rigid schedule for treatment that the patient must adhere to. A phrase you hear a lot about when people start to get a little nervous that patients are not doing what we want them to do is supervised neglect. And supervised neglect is a phrase that I think was created by malpractice attorneys and management consultants in order to justify dismissing patients that are troublesome. Patients who don't do what we want them to do. The usual scenario for supervised neglect is when patients go to a different practice and a different dentist starts looking in their mouth and identifies areas that that need attention without a lot of times the entire context of the patient's relationship with their previous provider. So supervised neglect, but what about for every patient that's sitting in a dental chair refusing dental x-rays, and we're afraid that they're going to sue us for supervised neglect, there is literal patient neglect. People are being neglected. Diamante Driver died from a tooth infection. These two nursing home patients are patients of mine that I have seen, and they have advanced dental disease. This picture on the left is an addict in a rehab facility. There is no one knocking on the door of these facilities to treat these people. Is that supervised? That's just plain neglect. So, I think sometimes we forget that dental treatment is elective. Nobody needs to walk into your office at all. And sometimes when people come in, I think we get the idea that we know more than them and that they're lucky that we're there, and we treat them with a lot of disrespect. So, and how did this all happen? Well, we can talk a little bit about dental history. You know, early humans didn't even have decay or malocclusion. They had nice, great big jaws and plenty of room for all their teeth. You know, and for thousands of years, the medical religious medicine model was the standard of care. Was, you know, health is God's will and disease is a punishment for sin. And this attitude has carried over into our present day. Hippocrates was the first guy to say, hey, it's not God's will. There's actually other stuff going on there. And he came up with the Hippocratic Oath, do no harm. And that's been a big inspiration for me, patient autonomy and do no harm. Am I harming people? Galen was one of the first pharmacists. Descartes, he discovered the pineal gland, and I've been doing some reading about the pineal gland and this DMT molecule. They're calling it the spirit molecule. That it's a chemical in the brain that can make you feel like you're connected to God. But he also liberated scientific inquiry from religious dogma. You know, dentists were a skilled trade for thousands and thousands of years. And barbers and midwives did a lot of dental care because dental care consisted of removing teeth that hurt. The first American dental college wasn't even started until 1840 in Maryland. And in 1907, Alfred Phones taught his cousin Irene Newman to how to educate patients and clean their teeth. And on the right of the screen there, you can see part of his book, a little outtake, The Principles of Dental Prophylaxis. In the Eastman Dental Dispensary, I live in Rochester, New York, and George Eastman donated the money to open one of the world's first ever dental public health clinics. And you know, I have nursing home patients that can't tell me what day it is, but they can tell me about their visit to the dental dispensary in the 40s. You know, George Eastman didn't intend to create a generation of dental phobics, but that's kind of what happened. But at least they have teeth. So in 1916, Dr. Weston Price recognized the connection to the mouth, and the mouth and the body are connected. And sometimes I feel like that's news to us because we've come to focus on just the teeth. This is his book, Nutrition and Physical Degeneration. And he realized that the diet has a lot to do, not just with decay, but with oral function and oral formation. So over time, with better diagnostic and operative technology, we've started to focus more and more on the teeth and not so much, you know, early dentists were midwives, physicians, and the mouth was treated as part of the whole system. But in the last, especially 50 years, we've been narrowing our focus to the teeth. Preventive dental care developed starting about the 60s and 70s, and decay rates were going down. Cosmetic dentistry was introduced in the early 80s because there was a fear that dentists were going to run out of cavities to fill. Children growing up in the 70s, the 80s, because of fluoride in preventive dental care, the New York Times published an article called The End of Dental Decay. And we, of course, know that that didn't happen. And private practices began focusing their attention on attracting and treating middle upper class patients with insurance and money, and kind of not really thinking about, you know, the rest of those people, their disease didn't matter. So orthodontics became common. And, you know, of course, today we understand that straight teeth not just look nice, but they're part of a full system. Dental product manufacturers jumped on the cosmetic trend, and now people spend billions of dollars every year on products to change the shade of their teeth. And the shade of your teeth, we know, has absolutely nothing to do with anything, but yet we recommend that patients change the shade of their teeth. We sell them products to change the shade of their teeth, and patients are always interested in buying products that change the shade of their teeth. And you can get your teeth whitened in a salon. You know, when I show this picture, I give a presentation once a month to the new nursing staff at the nursing home. And when I show these two pictures, that top picture elicits gasps of horror. Oh my gosh, those teeth. And I have to tell them, these teeth might not be very pretty, but they are perfectly functional. I want you to look. I show this picture as an example of what healthy gum tissue looks like. And these people absolutely can, the students are so focused on the color of those teeth that I have to really draw their attention to these beautiful, light pink, firm, healthy gum tissues. Now the bottom picture, those aren't even real teeth. That's a bridge. But look at the tissue. But nobody says a word about the bottom picture because those teeth are pretty. Also, the role of the dental hygienist has changed significantly. When Dr. Phones created our profession, he said the education and training of dental hygienists does not aim to produce mechanical operators, yet here we are. So we've gone from public educators to private tooth cleaning salespeople who create income for a dental practice. And look, lo and behold, that's a lot. A dentist told me, your job is to fill my plate. And, you know, in 48.48 seconds, I got 88,500,000 results on how to increase hygiene production. Sometimes I think that doctors would prefer a chimpanzee. And don't forget the PPE and the Depends, so we don't have to take bathroom breaks. Meanwhile, in other forms of medicine, the tongue and the mouth are used for systemic diagnosis. In Chinese medicine, from the coating of your tongue, they can make a systemic diagnosis. The same thing with Ayurvedic medicine. The human tongue is pretty amazing. And it's more than just something that gets in the way when we're trying to clean their teeth. The human tongue is capable of much more than we use it for. We could be carrying grocery bags with our tongues, but we don't. We could be doing what this giraffe is doing. We just don't, because it's not socially acceptable. We would have to, you know, do a tongue workout, but we could do it. So when a patient has a fat tongue, or a tongue that seems to want to intrude on, pardon me, their dental treatment, it can sometimes, rarely be actual microglossia. This poor woman has a disease which has caused her tongue to enlarge. Most of the time, it's not. Most of the time, the tongue has low intrinsic muscle tone. This is me. So when I first started learning about oral facial myofunctional therapy, my tongue, I couldn't do anything. And now look, just with regular exercise, the muscle tone in my tongue has increased tremendously. And look at the change in my chin from the one picture to the other. I can almost do 5. I can do 3 folds easily. And in the second picture, I can almost do 5. So the tongue responds to exercise. If a person's tongue is restricted, it's going to have a lot less ability to move when we're trying to work in their mouth. That's my tongue on the lower, in that lower picture. And my tongue is tethered, but I have not had it released yet. So correct tongue posture is when the tongue is up in the palate. And that was one of the very first things I ever learned in myofunctional therapy, and was absolutely mind-blowing. What? The tongue's supposed to be up there? So the vast majority of people have low tongue posture. Their tongue is not up in their palate, it's sitting down. Your mouth is the entrance to your airway and your lungs. You know, if we had different eating and breathing tubes, we'd look really different, and we might not be able to speak, but we would be a lot healthier because, and I'm going to explain that. So the entrance to your lungs is completely made of muscle and soft tissue. Look at this. There are no bones. There's no bones beyond the end of your mandible in the back of your throat. So your throat is being held open by your skull on the top, your maxilla and mandible in the front, and this your spine in the back. But look at all this space that's there's nothing there. There's no bone to hold it open. I've always wished that we had a wishbone under the uvula that would hold open our airway, but I'm not in charge of that. The hyoid bone is this little teeny bone in your throat, and it holds up, it forms like the basis for your whole, all that muscle. And it's just this tiny little bone, and it doesn't articulate with any other bones. So your entire respiratory tract and digestive tract is very dependent on this little tiny bone, the hyoid bone. So as you can see, it's entirely made of tissue, layers of tissue, muscle. Now, you know that muscle, if you don't use it, doesn't have good tone. And your skull is the framework for these muscles. If you have, if you've changed out the material of a tent, but you don't change out the frame, you're going to get drooping. It is exactly what's happening inside of your mouth, everybody's mouth. Modern skulls are smaller, and the tissues are sagging in the back. The human skull has shrunk in the front because of our ability to speak. So look at the difference between the primate tongue and the human tongue. So the primate tongue, they have that beautiful foreface. I always tell my patients, you never see a gorilla with a CPAP, okay? They have plenty of room for their tongue to be up and forward and out of the airway. That's the big difference. And primates are obligate nose breathers. Look at that arch. Oh my gosh. That is a thing of beauty. So humans have turned into mouth breathers, and mouth breathing drags down your face. It doesn't clean the air before it enters your lungs. It dries your mouth, and it actually creates asthma and makes it worse. George Catlin wrote a wonderful book in 1870 about close your mouth and save your life. He understood that nasal breathing was linked to good facial form and a healthy dentition. I love this picture of the police because it shows so beautifully the difference in facial formation. Stuart Copeland, the drummer on the far right, he probably was fed with a bottle and had a lot of had a stuffy nose and did a lot of mouth breathing, because look at how long his face is. Sting in the middle is perfect. He's got that nice the nose, his face is proportional. Andy Summers over on the other side, he's pretty close, but he has his face is a little smushed in. The bottom part of his face, his jaw, his mandible is a little small in comparison to his upper face. If you want to know more about that, read anything by John Mew. He's so wonderful. He talks all about it. So while I was looking at the police, I thought, hey, I thought about the Bee Gees because I love the Bee Gees. But also, so here's Robin, here's Barry, Robin, and Maurice Gibb as children, and this is what those faces develop into over time. Robin and Maurice were twins. So look at literally the same gene pool, but look at the difference in their facial formation. I actually think that probably Robin was on the bottom. And so that's part of why he has that long face. But again, Barry seems to have won the genetic lottery in terms of, although they all have sort of smallish mandibles. But, Robin has the classic long face and Barry has the nice proportion. So mouth breathing is going to create these annoying patient behaviors that people write about on Facebook, in Facebook groups. So frequent rinsing, frequent spitting, fogging the mirror, and pushing the mirror out of the mouth with the tongue. These are all related to mouth breathing. And your airway trumps everything. Okay, your brain needs oxygen and it's going to get it no matter what. The tongue is the guard for the airway. So when patients don't have enough oxygen, it's oxidative stress. And I read this article. This is in James Nestor's book, Breathe. SM was a patient. She had a dysfunctional amygdala, and she literally could not experience fear. Psychiatrists exposed her to myriad situations which would scare any normal person, and it didn't bother her. But when they blocked her airway, when they plugged her nose and mouth, that was the very first time she ever experienced what we would label as fear. She panicked because she couldn't breathe. So oxidative stress creates fear. Oxidative stress can also create euphoria, which is when, you remember that choking game they used to, you heard about for a while, where, you can choke yourself to get, if you don't kill yourself, you, for a brief moment, you can get that feeling of euphoria. DMT is the spirit molecule that it's in your brain, and there's certain ways of breathing that you can induce it. Wim Hof is known as the Iceman, and he specializes in breathing techniques that help release this DMT into your brain to promote this feeling of well-being, euphoria. He also recommends that you take ice baths. I'm not so sure about that. But his methods have helped a lot of people regain their health. Wim Hof. So oxidative stress and dental decay. What? So oxidative stress causes inflammation, and the first step in the caries process is reversal of the dentinal fluid flow. So before you even have the acid attack, we have inflammation, which causes the dentinal fluid to go out so that the acid can come in. Who knew? Another article, more and more research is coming out about dental decay and where it comes from. And it's not just about brushing and flossing. So what? No schmutz mouth? That's for years. That's what we've been doing. We've been shaming people about their oral hygiene. We're judging them. We're making it into a moral implication of a biological process. So, your body, the human body is built to survive. Okay, it's going to survive. And if it can't get what it needs, it's going to compensate. Homeostasis is what the body's looking for, and your body is going to compensate to keep your airway open. So compensations, especially when you're thinking about patients presenting in the dental office, okay? If they're mouth breathing, if they're fearful, they're going to present physically in defensive. They're going to be angry and they're going to be isolated. Look at people when they're sitting in the waiting room. They're crunched when they're down like this. These are all compensations to cope with oxidative stress. And we label the patients based on their compensation, and we approach them based on the label. In Surdentity, what I tried to do was to create different patient labels, hoping that if you change the way you view your patient, your approach to them will change. And what I did was broke down patient presenting archetypes so that you could say, you know, they're presenting as hostile, presenting as hysterical, presenting as controlling or a clown or submissive, rather than what we usually label them as, you know, they're a jerk, they're controlling, they're demanding, they're touchy, they're a jumper, she's a PETA, they're sensitive, they're a gagger. You know, that just, it's a gagger. That's like, they're a human being with a reflexive behavior. And the one thing that they do becomes the entire label for their, you know, for our whole experience treating them. I'm going to talk more about that. You know, and patients are aware that we're judging them, which is partly the reason that they come in and they feel defensive and want to protect themselves. I've had patients tell me these very things. They make me feel like I was a bad patient. They make me feel like I'm dirty. They call me a baby. I hate this. You know, it's not like they don't know or they're not aware that this is not a good experience for them. And they're not doing it on purpose. So judgment. You know, judgment comes like that from what I talked about, the medical religious medicine model, that patients are at the fault for their disease. And it's easy to do with dental disease because, well, we've always thought the cause was local, but now we're starting to understand that maybe it's not so local. And maybe it's not just that they're a slob that doesn't floss their teeth. Maybe there's more to it. And, you know, we write them off as a schmutz mouth. And so prejudice is when we form an opinion, an adverse or opinion or leaning formed without just grounds or before sufficient knowledge. So the patient, we become prejudiced based on the label that we put on that patient. Back to in Surdentity, you know, I talked about the emotional experience is what the patient remembers. We assess our interactions from the clinical aspect. Patients don't care about our technical skills. They really don't know the difference. They know, did it hurt? How much did it cost? Those are the things that patients care about. When you're dealing with somebody who's been traumatized, you are not dealing with a normal brain. You're dealing with hyperarousal. So a patient who's been traumatized is going to come into the dental setting already in a state of hyperarousal. Their heart's racing, their digestive system shut down, and they have the physical symptoms of panic. You know, your brain is miraculous. It turns non-matter into matter. Your brain turns emotions into chemicals. I've said for years that the brain is a chemical stew and our feelings are the flavors. But what I'm coming to understand more and more is that oxygen and carbon dioxide are the salt and pepper of the brain stew. Okay, if you have too much of one, or not enough of the other, the whole stew, the flavor is going to be off balance. If you read The Oxygen Advantage by Patrick McEwen, read Breath by James Nestor, there's so much, pardon me. My mouth is drying out because I'm a mouth breather. There's so much great information in those two books about oxygen and carbon dioxide, and how, yes, we're breathing, obviously, because we're alive, but we could be feeling so much better. All right, so oxidative stress is going to create a negative emotional experience, and it doesn't matter what you do to your office. Okay, if you know, these pediatric practices are like Disneyland. You know, it's like really fun when the kids go in there, or you go into an office, it's like a spa, so luxurious. There's aromatherapy and blah, blah, blah. And those things are helpful. However, if the patient can't breathe, it doesn't matter how luxurious or fun the surroundings are. They're going to have a negative emotional experience. And kids these days, their airways are smaller than ever. And I just put that together fairly recently because I'm seeing these kids that are so afraid. And I'm wondering, gee, I wonder why that is. It's not like, but it's their airway. You know, these kids are mouth breathers. And if you're a mouth breather and I put something in your mouth and you can't breathe, you're going to get scared. It's that simple. So neuroplasticity is awesome because we can form new pathways in our brain when we repeat behaviors and thought patterns. But in order to work well, your brain has to have the proper balance of oxygen and carbon dioxide. So oral movements, reflexes, and how they affect patient behaviors. So oral reflexes are movements of muscle that are not voluntary. They originate in the primitive brain. And they generally, you're born with them. They should integrate over time, but sometimes they just don't. So here's the oral reflexes: root, suckle, snout, gag, transverse tongue, swallow, and phasic bite. So you don't have to teach a baby how to suckle and swallow. You put the nipple in their mouth and they know what to do, and they know how to swallow. Those are reflexes. The gag reflex is also a reflex. Oral motor patterns and movements are not as strongly rooted as reflexes, but they're very strongly conditioned, so they're just as difficult to deal with as reflexes. The gag reflex is just that. It is a reflex. The patient is not doing it on purpose. It's an adaptive, vital mechanism for survival controlled by this parasympathetic division of your autonomic nervous system. And again, if the tongue's job is to guard your airway. And if your airway is mostly, if you're breathing through your mouth and I put a bunch of stuff in your mouth, your tongue is going to do what it's supposed to do, which is push it out. So that's what a gag reflex is. You know, there's lots of articles about that too. Some people have tried salt on the tongue. Some people have tried just, you know, trying to distract the patient. You can retrain somebody out of a gag reflex, but it takes a long, long time. What I have observed with my myofunctional therapy patients is as their nasal breathing gets better and they get better muscle tone, their gag reflex gets better. It decreases. So when you have a patient that refuses X-rays, if you look in their chart, it says gagger, and it says refuses x-rays. There are ways to be a little bit more proactive about patients like that. Before you even seat the patient, look at their old x-rays. Okay, if you see that it's open between the arches, that the occlusal line is slanted, that you can't get past the second molar, and these other things, there's overlapping in the posterior frames and not the anterior. These are all indications of that patient does not tolerate x-rays well. And a patient who refuses x-rays, that might be the actual reason that they're refusing the x-rays. Okay, not because they don't have time or the money or the insurance or any of these other things. They refuse the x-rays because they're afraid. They don't want that. They're well trained in that fear. Every time they've had dental x-rays, it's been horrible for them. So why should I insist to this patient to do a procedure that they view as horrible? When the patient sits down, and then when if I try to talk them into it, or worse, strong arm them by threatening them with, well, we have to, it's the law, blah, 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 that creates a power struggle, and that appointment is not going to go well. So I've looked at the patient's x-rays before I even seated them, and I see, oh, wow, I'll bet you this person doesn't like x-rays. The patient sits down and I look at them. And if they have scalloping of the tongue, if they have a tongue tie, if they have tori, and right away, if I see that their lips are chapped, they're mouth breathers. And some patients, I can hear them breathing when they're walking in the room. So I know right away, okay, this person is a mouth breather. I'll bet you that, they probably don't like dental x-rays. And let me tell you something, patients really appreciate it if you say to them, I'll bet you don't like dental x-rays, huh? How did you know that? I'm like, I could just tell from looking at your other x-rays. When I look in your mouth, I can see you have these bony protrusions. I can see that your tongue is tethered. Yeah, you're right. I've always hated them. Yes, I know. You know what? We're going to get these done, and I'm going to coach you through, and we're going to be fine. So, going from you need to have x-rays and I'm going to make you sign this piece of paper if you don't do it, to I really should take these x-rays. I know you probably have a bad experience, but I'm going to help you through this. Okay. Two different approaches to the same scenario. So I've come up with a protocol that I've been able to get x-rays on 90% of my patients. You have them breathe in and out exclusively through the nose for a full 60 seconds before you do anything. And have them focus on the philtrum, have them really feel this air coming in and out here. When I get ready to place the sensor, have the patient inhale through their nose and hold their breath. They open the mouth, I place the sensor, and while I'm pressing the button, they are exhaling. Gagging is about inhaling. If you are exhaling, you cannot gag. You cannot gag if you are pushing air out. It is impossible. So have that patient focus on pushing the air out, 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 out. And by the time it only takes a few seconds to get the exposure. And then as soon as the exposure, okay, you can open. So some patients I actually have, I either place my finger or I have them press their finger right here on their filter and say, I want you to focus all your attention right there on that spot. So remember, if a patient is gagging, they are trying to breathe in. If you have them hold their breath and focus on breathing out, they cannot gag. The snout reflex and the root reflex are other things that that happen. I notice these more in my nursing home patients, that the snout reflex especially. That's when you touch the lips and they go like that. Either a pursing or like the upper right picture. When a person is pursing their lips, they're going to have very heavy plaque on their lower interiors, because when they're brushing down there, it feels like they're getting to the bottom. What they're hitting is that muscle. So when I'm working in that area, I have them make sure that they bite their teeth together and I pull their lip down. And I remind them, breathe through your nose, breathe through your nose. And this is, I have to repeat it over and over and over, because people breathe through their mouth. They just do. And when you're, you can instruct them to do the same thing at home. Okay, when you're brushing your teeth at home, make sure you close your teeth together and breathe through your nose so that you can get down to the gum line on those teeth. Cheek tightening is another reflex. I notice it mostly in my nursing home patients, where even if they open their mouth, these muscles tighten. Not so much the orbicular oris, but the axillary muscles, and they tighten up. And when you're working with that, again, have the patient close. It's amazing how much room you have when patients are so used to us yelling, open your mouth, open, open. When you have them close their mouth, there's so much more room. You can retract the tissue. If these people have third molars, there's always a lot of heavy plaque. And I always start my my treatment from the back to the front. And I instruct patients to do their oral care at home from the back to the front. When you start in the front and go to the back, first of all, you're going to make yourself gag. And second of all, you're going to miss the back surfaces, because as you go toward the back and open, you're hitting the muscles. You're not even getting the teeth. You guys all know this. When you have a patient who's got a tongue thrust, again, that's it's a mechanism to protect the airway. So you don't leave the saliva ejector in their mouth. To me, that's just so rude. I work with the saliva ejector in my left hand, and I use it continually. I use it as retractor. I use it to minimize, suction, retract, so that my patient doesn't have liquid in the back of their throat. And I see these snarky memes in dental hygiene groups. It's just saliva. You can swallow it, Well, people can't swallow when they're laying down. And people who breathe through their mouths can't swallow and breathe. So stop judging them and just get it out of there. All right, we're coming to the end here. Modern children are in a crisis. They are being born with mandibles that are just simply too small. And these kids have airway issues. Look at that little baby on the left. Isn't that so cute? Puffy cheeks and rosebud lips are adorable when you're one, but this kid, that is highly unlikely that that's going to evolve into a functional oral motor system. And it's so important that we get to these kids while they're kids, because you can do so much proactively that is so difficult to do later in life. The American Orthodontic Association now says 7 years old. for their first by 7 years old. Most kids are ready for an orthodontic examination by the time they're 4 or 5. And if we need to, start talking about it and get orthodontists on board and get parents on board to know that crooked teeth is not just a cosmetic problem. Crooked teeth means that there's something wrong with the whole system. It's not functional. So in order to help these kids develop good jaws and airways, we want them to breastfeed for a year, no pacifiers, no sippy cups, no digit sucking, and encourage nasal breathing and thorough chewing, which means this child needs a diet that they have to chew. Modern food is so soft, and now kids are squeezing mush out of bags. And because of that, they are absolutely not going to develop oral motor systems that are functional with room for a healthy airway. Forwardonics.com, GoPex, has a lot of great information about. GoPex is a book published by Dr. Sandra Kahn for kids and parents about developing good oral posture. And the MyoMunchie, which you can ask your dental provider about, but parents can order a MyoMunchie on their own. They are great for children, babies and children, and the kid, you just have them chew on it, and it helps to develop a better working orofacial complex. All right. Wow, we got through it. So here are my resources. It's they're all the book Teeth by Mary Otto, Breath by James Nestor, the Oxygen Advantage by Patrick McEwen. This is thank you so much for your attention, and I'm really so grateful to be able to do this, to share this knowledge with my fellow professionals. Our jobs are hard, but we don't have to make it harder. There are things that we can do that will make our jobs easier, and I hope to see you again. So thanks. And thank you, Shirley.
Thank you, Beth. This was really great. It was nice to have a little bit of that history up in the front, and then really just kind of dive into what is causing this gagging. Why are people gagging? What is it? Is it about us? No, it's about them. And what is it that we can do to make their appointment better? The only thing you didn't talk about is when you run into these patients and it's time after time that they're not able to find comfort during an appointment, that those would be good people to refer to a myofunctional therapist.
Excellent idea.
You can do some myofunctional therapy in your dental office. I found it to be helpful to ask people to I would press on their tongue and then ask them to relax it, and then just relax it. And then, did you see you pushed against it again? Now just relax, and just really focus on relaxing the tongue. And, that's one thing that I did. You offered a bunch of other solutions, but sometimes they just can't because there's something else wrong.
Absolutely.
And that would be the time for an actual referral.
I completely agree. And the more hygienists know about oral motor disorders, that's the key. Yeah. Is informing our fellow professionals about what we can do for these people.
Exactly. And I'm really happy how you address that standard of care conversation. Bullying isn't part of standard of care.
No.
And I don't think there's a single hygienist in the world that thinks that they bully their patients, but I bet you there's a lot of patients who think that they're being bullied. I'm sure that people thought I was bullying them, and I'm like, I don't know what else to say about that, but just really check yourself as a professional. Um,
Well,
how heavy handed do you have to be? And the standard of care is a law, and it is about the legal system. It's not about what you do or don't do, or what the local association is telling you you should or shouldn't do, or what people are charging for, you know, this or that,
Right.
and your zip code and all that. So that's also usually very unclear to a lot of professionals
Well, there's a lot of fear.
from
I'm-
everywhere.
Yeah, well, Don Miguel Ruiz, who wrote the book, The Four Agreements, talks about the track of fear and the track of love. So I, not only in my everyday life, but also in my professional life, what's the most loving thing I can do for this person? And patient autonomy is the most loving way. It's their decision.
Yep.
It's their decision.
And if you can't do your best job based on their decision, then that would be a time to make a referral to someone who can help
Right.
you help them.
Yes.
That is not, it's so easy to just go, well, screw it then. I'll just polish the fronts of your teeth and I'll charge you double and send you home. But that's the attitude that's perceived, I think, is probably the easiest way to say that. So I'm looking forward to your next presentation. I hope we get one soon. Even if you could do it every quarter, that'd be awesome on so many of these pet topics, because they're fun and they're interesting and there's a little different spin to it. So awesome. All right. Thanks, Beth. Have a good night.
All right. You too. Thanks a lot.
Bye, Diane.
Bye, Diane.